And of course, there will be many, many questions. But the last talk, Jan Bess just showed that there is a chronology of GALAD. That means it increases before you can detect the tumor by ultrasound. And something what Dr. Lieberman also alluded to, that you have a phase, an early phase, where you can detect the tumor by serology, and you don't see that by ultrasound. But we stick on ultrasound. So we think that, the first imaging is ultrasound. So do you think we should move to another imaging, let's say PET or something which could be, more sensitive?
I think the big issue is, of course, the high burden of costs that are associated to MRI diagnostics, then also the ongoing discussion of liver-specific contrast agents that might make physical harm. So I think, Professor Ramadori, what we really need to identify is the precise cutoff where the probability that we already have early HCC is apparent, because the problem is if we perform MRI too early, I think it will not be cost efficient. So I think we need to collect a lot more of data. On the other hand, I also think that the quality of ultrasound is very inconsistent. I don't know, maybe the other colleagues could give some input, but I think in Germany there is a very strong heterogeneity of the quality of ultrasounds across the different centers. So I think what we really need would be a prospective study comparing high quality ultrasound with the prospective utilization of the GALAD score before we can clearly answer this question.
Thank you. May I add, let's say, if you do a follow-up by ultrasound, you start with a small tumor and you follow that. To my experience, it was that suddenly you do ultrasound. 6 months ago, there was no tumor. And now I have a big tumor. I wouldn't predict that size. Maybe Massimo Colombo can say something to that.
Hi, Giuliano. Nice to meet you. Well, let me put a question on my side. For instance, we are well aware that there are metrics that allow to score and grade the quality of endoscopies when they are challenged in the surveillance and screening for colon cancer. And these metrics are being, re-evaluated quite frequently, and there is now some argument going forward on how to further improve these metrics. To my understanding, there is no metric at all that allow to qualify ultrasound-based screening has been performed at a high level, medium level, or at a low level. In other words, we miss completely standards, metrics to assess the quality of ultrasound. In America, the vast majority of screening is being carried out by technicians. Why not? They might be very good, but whereas in Europe, most of the ultrasound-based screening are being carried out by internists or radiologists, doctors. But even in this domain, we still miss metrics to score, to assess the quality of ultrasound-based screening. And this, in my opinion, is a black hole.
Very important, very interesting, yes. I like to ask Dr. Ma. Are you here? Yes.
Yeah, I'm here.
Okay. Thank you. Congratulations for your outstanding presentation. I enjoy a lot. It's just a more philosophical question about single cell. And how much information are you losing when selecting a type of cells? For example, cancer cells or hepatocyte, you are losing information in comparison with the overall approach that we are using in a standard situation. Do you think that the information you are catching from the single cell you are selecting could be enough to replace the information you are losing, not taking account the rest of the cells involved in the process?
Thank you so much for the question. I think it's a very wonderful question and also a kind of challenge in the single cell field. So as you may know that single cell technologies, we're trying to profile the tumor cell communities, but during the kind of library preparation or during the single cell suspension preparation, some of the cells may tend to kind of die, but some of the cells tend to survive. For example, immune cells, they tend to survive, but sometimes tumor cells, they tend to die. Then the number of cells may be kind of imbalanced in the kind of single cell community compared with, for example, bulk analysis or other types of analysis, for example, imaging, histology analysis. But in our in our multiple regional analysis, by sampling different locations of tumor cells, tumor cell communities from different locations, and we found that the tumor cell communities, especially for the kind of tumor cell profiles, are very stable among different sampling locations, and thus we think that sampling bias may be minimum, and if there's any. But of course, for example, the number of cells, number of immune cells, and number of stromal cells may vary across different sampling locations. But I think that this is a kind of challenge for single cell research. In addition to that, I think the combination of single cell research with other kind of technologies, for example, histology, as well as the mRNA, MRI, and you kind of mentioned earlier, as well as other kind of spatial knowledge, spatial techniques currently available in the research field, for example, spatial transcriptomics. And by combining those kind of technologies together with single cell research, I think this kind of combination method may provide more insights into the into the research of liver cancer, as well as maybe provide new biomarkers for liver cancer prognosis, diagnosis, intervention. Thank you so much.
Wonderful. So we have a question in the chat. No, I cannot find now.
I can ask a question to Dr. Lieberman. Dr.
Yes.
Lieberman, you are looking for low abundance proteins. What about low molecular weight proteins? Should you maybe add to your armamentarium also urine?
We definitely could look at urine as well. It's more a challenge with regard to having cohorts where urine was collected. So which is much less frequent. And so we definitely can do urine, we can do any kind of biofluid or tissue or exosomes isolated from urine or plasma, or whatever. So it's not so much the technical challenge as it is a question of what is available.
Let me to ask a question. Is also quite complex, but my question is, if you are using the somalogic approach, you are detecting the proteins number from 1 to 13, and taking account the Gallant result. In spite, I'm not asking about what is the overlap between both approach. The Gallant, we select, or people from Roche select 3 different proteins, You are looking for in free hypothesis approach, the protein that could predict liver cancer. What is can you anticipate the overlap between both approach? Do you think we need to validate one each other?
I mean, again, ideally, it would be to combine them potentially, the GALAT with proteins from our biomarker discovery. So far, obviously, in these population cohorts, we don't have any kind of AFP ultrasound data available. But in the cirrhosis cohorts that we have started, and obviously if someone here on the call has cohorts available where they have actually serial samples of serum or plasma, we could actually perform all the analysis and then both do a side-by-side comparison as well as a combination of our proteins with ultrasound, AFP, DCP, and there's a whole GALAT score to see how we can either further improve performance of the GALAT score or see whether or not ours in combination with one or the other components of it would actually lead to the highest accuracy and highest AUC.
Okay, perhaps we can try to do that for sure. Congratulations.
That would be great.
Yeah, I think Professor Manuel Luis has a question.
We have a question about
Yes.
mention.
Oh, sorry. I
Sorry,
had a
sorry,
question
no.
for
You.
Dr. Minguez, which is about liquid biopsy. Usually when we talk about liquid biopsy or circulating tumor cells or cell-free DNA, we're talking about blood samples. But have you seen something about ascites liquid?
I haven't reviewed this point because most of the papers, as you have mentioned, are developing in blood. And I guess that in ascites, could be because at the end, no, portal hypertension could be somehow a mechanism for filtrating this kind of products, but I haven't seen it. I don't know.
Okay.
I have also, Beatrice, a very difficult question, but for you it could be easier. What is your idea if we can take samples directly from the portal vein using ultrasound, endoscopy ultrasound? We can take directly the blood from the vein, from the portal vein. Do you think a liquid biopsy could improve a lot the results in this field, or not?
From my point of view, and maybe you are right with this, but I honestly think that the point of liquid biopsy is to have an easily obtained biomarker. So the complexity in the way of getting the sample maybe is not the point from my point of view. For me, it's something that could be ideally easily obtained, easy to repeat with no problems for the patient. So I guess that for academic proposal, maybe we can try to design something to really verify if we are obtaining more cells or I don't know, whatever the marker is. But to translate it into clinics, I don't think is ideal, because at least you will need to, you know, to canalize to punch the portal vein, so at the end it's not so easy. Even
for sure, we need to implement the 5 rules of Manuel Rodriguez Peralvarez when we are discussing about biomarkers. I completely agree, but we have a discovery part in which perhaps we can use more complex approach in the obtention of the sample, but also in all the devices we need or the technology. And in the second part, in the validation, in which we need to take into account for sure if the final diagnosis should be done using that, for sure is not available in the majority of the centers. But perhaps it could give us some idea about the mechanism or about which could be the potential biomarker that we need to move for an external validation, how it's moving over the time, and we need to calibrate and to find exactly what is the relationship, the linear or not, and for sure using artificial intelligence, because I fall in love with your presentation, Manuel, and your 5 rules that I think we need to put all time when discussing about these different biomarkers.
Thank you. I hope we can still be friends after bringing up all these lacks of of limitations of our methodologies.
Yeah, for sure. But during the webinar, I was taking note, and at the end of the day, we have at least 2 or 3 of your rules. If it's curious how the development of potential biomarkers, perhaps the GALAD has a very strong development, no? Giving you some answer to your question. What is your idea at this time? Allowing us to discuss about GALAD in spite we were not.
I think GALAD is very attractive because it combines several biomarkers, and this is clearly the way. And I think, of course, that we need to further validate in other scenarios, and probably it would be nice to see how the same biomarkers combined with a different methodology, which is machine learning methodology, would provide better accuracies or not. And this could be tested, because I have seen that there are huge cohorts going around to do this.
Wonderful. Perfect. Dr. Son?
Yeah, I also would like. I don't have a question, just agree with the comments. Ideally, a simple test can be applicable for early detection for liver cancer across different etiologies. As we all know, there is a huge heterogeneity of etiologies of liver cancer across the world, but I feel there is a long way to go to have meaningful biomarker panels that can be of clinical utility in different populations worldwide.
I have my last question to Dr. Best about GALAD again. What is the risk of false positive that you can detect using GALAD? A patient at risk of advanced cancer, but at the end of the day, the patient is not suffering from hepatocellular carcinoma. What is the risk of this false positive, and how are you addressing in clinical practice?
Well, of course,
example, MRI, for example, studies.
Of course, the most important prerequisite is that you always keep in mind that patients should not be under warfarin therapy, because this is influencing the DCP. So if you have a vitamin K deficiency that's induced by medications, of course, you have to always keep this in mind. And I think the risk of false positive is a bit ruled out by the fact that the highest risk of false positive is with AFP. I even had patients with IFP levels of 500 and they only had a chronic hepatitis C. We ruled out HCC via MRI, and then we started the DAA therapy, and then the AFP dropped from 500 to normal, and everyone was convinced this patient would have HCC. So if you combine the biomarkers, I would even think that it's reducing the probability of false positive results. And the only thing that I really think what we have to work on is, do we have different cutoff thresholds at different HCC causing etiologies? So I think when we performed our NASH project with GALAD, we could see that the NAFLD patients have quite different GALAD cutoff scores. And so I think we really have to adapt the cutoffs for disease etiologies. And I think our experience is too low. And I think we really need prospective data to avoid of those false positives depending on cutoffs. So I think there's still a lot of homework to do to avoid this.
Wonderful. Thank you.
I have, if you allow, the last question to Beatrice. She showed a nice curve of a patient who developed HCC after DAA. And she followed that really, quite close, right?
Mhm.
The tumor appeared at what, 6 months or less than 6 months?
Yeah, it was less than 6 months after the second treatment. And I have to say that I didn't explain it for questions of time, but this patient wasn't treated at the very beginning because there was this concern about the treatment and the rising of hepatocellular carcinoma after the treatment and all of this. And so after more and more research and showing controversy, because at the end it's still a little controversial, we decided after all this time of stability, treat the patient. It was almost 2 years of follow-up. So was it a casualty or was it really related to? I honestly don't know. Of course, when you see it, you can you try to link it, but at least it was not an early relapse, no? Because it was academically, at least the cut point of 2 years was superated, but who knows? No? At the end, it was an early stage HCC, not a recurrence. I still think that we need to treat the patients, probably with careful follow-up, but it's not something that I would deny to patients the treatment of hepatitis C. Sorry.
Okay, thank you.
It's to you.
Wonderful. I think there is a question from Dr. Urba in the chat. Dr. Urba, would you mind speak up, or are you there? I think the question is, what about my methionine cycle disturbance and the lack of SAM in HCC cells? I wasn't sure what this question directed to, but if any of the speakers have any thoughts on that, please speak up.
Thank you very much. This is characteristic to hepatomas to have a very low level of S-adenosylmethionine, and this is in the beginning of carcinogenesis. And I would like to ask how it can we see in the liquid biopsy some traces of this process of carcinogenesis. SAM is not among markers, but possibly when we have biopsy of tissue, we can detect this. Thank you.
I think the best approach to study that would be a metabolomics approach. I'm not familiar whether or not any metabolomics has been applied for liver cancer research.
Yeah, I have been involved in some metabolomic studies for example, the liver cancer brain project, where we have over 10 prospective cohort studies of initially healthy individuals, where the pre-diagnostic blood samples were available for those participants. And the effort has been led by Dr. Catherine McLean at NCI, our group, a part of that. Hopefully in the next year also, we can have some metabolomics data from that cohort consortium. Meanwhile, I think there are emerging evidence or studies has been published in terms of metabolomics and liver cancer worldwide. But still, I think the relatively early stage of studying the liver cancer.